right. Welcome, everybody. Thanks so much for coming out tonight. I'm Monty Powell. It's always a pleasure to do this particular meeting because it's just a bunch of familiar friends in the audience at sessions like this. So thank you all for coming out. I know there's a lot of different places you can go in this fabulous city, but we appreciate you being here with us. Tonight I've got an all-star panel. I think everybody in the room here knows who I'm up on stage with, Dr. Tannir from MD Anderson, Dr. Zhang from UT Southwestern. Huge thanks to PeerView for providing this session. I think this is always highly educational and great opportunity for us to really duke it out over some of the data that you saw on the screen today. Also want to thank Aveo, Bristol Myers Squibb, Exelixis, and Merck for providing educational grants for this symposium. We're very grateful to them for continuing with these sorts of educational opportunities. If you haven't already, please take a moment to fill out the pre-event survey. And we're going to be doing a couple of polling questions throughout the evening, so you should have some iPads nearby you, and we'll provide you with some QR codes as well to answer questions throughout the course of the evening. If you're in the room, you can use your own personal devices. Something different that we're doing this year is we're actually giving out awards for the best questions. So if you submit questions to the portal, we're going to be giving out a couple of Amazon gift cards, and those will be mailed to you following the program. So we really want to inspire some great dialogue here this evening. Certainly visit us at peerview.com, and you can see all the slides and content that we're presenting here tonight. And we're going to begin with a test question. We're not going to see the answer subsequently, but if you could try to fire up your devices and scan this QR code. In your practice, which of the following represents a challenge to your decision-making in caring for patients with advanced RCC? Is it choosing between dual IO and TKI IO? Is it adequately describing to patients the efficacy results from some of these long-term studies? And again, there's so many updates that have been coming out in recent years, and that certainly poses a challenge. Is it sequencing therapies in the refractory setting, or is it effective management of AEs? So if you could just take a moment to answer that question on your devices, we'd really appreciate it. And certainly that'll inform some content for our future sessions. Okay, so as you're doing that, I'll review some of the goals for today. We really want to augment your knowledge around efficacy and safety for these multiple emerging treatment options for renal cell carcinoma. We want to offer some strategies for personalizing care and really develop a framework for the mitigation and management of adverse events. We'll focus some attention on that this evening as we go through things. My first special guest tonight who's going to be presenting is Dr. Tannir. He's a professor in the Department of Geomedical Oncology and an endowed professor at the UT MD Anderson Cancer Center in Houston. Nizar, before you jump into your talk, I want to ask you a question. After the event tonight, what's the best restaurant to go to here in the Kentucky area? I know you know this place well.
I think we're going to go to Porch Kitchen.
Porch Kitchen?
And Bar, yeah.
Okay, is that a good spot?
Well, I hope so.
Okay.
On their website, they say it's an elevated all-American, so we'll see.
Okay,
Elevated cool. American cuisine.
Okay, very good. All right, excellent. Well, with no further ado, Dr.
I'm looking
Tannir.
for my and some creamed corn and creamed spinach.
Simple. I like that. Okay, take it away, my friend.
Okay. Well, thank you, Monty. Thank you all for coming. It's a pleasure to be with you here again. And we have really a good program focused on RCC. My section, my part of this program is focused on first-line therapy with a dual IO, which is nivolumab plus ipilimumab. Just a little bit of history about how this whole thing started. As you know, sunitinib, pazopanib have been the first-line standard of care for patients with clear cell RCC for many years. So comes the revolution of immune checkpoint therapy to the field of RCC, and then you'll see there are 4 regimens that have been developed and 4 trials that brought us the dual immune checkpoint, nivo-ipi, and that's the CheckMate 214. And then, Dr. Pal will be showing you the data, the latest data from the 3 IO-TKI regimens. But CheckMate 214 was the first of these 4 trials that were launched. It's 10 years now, and I'm sure you're familiar. I'll just briefly describe the treatment schema. This was a large 1,096 phase 3 trial, 1,096 patients, comparing nivo-ipi versus sunitinib in first-line therapy for patients with advanced RCC. So the primary, there were 3 co-primary endpoints for that trial, OS, PFS, and ORR. And in the primary patient population, intermediate and poor risk by IMDC criteria. I'm sure you're familiar with IMDC. There were 2 stratification, geography, as well as IMDC risk. And I'm sure many of you have prescribed this therapy, and then I'm going to show you the latest follow-up that I presented at ASCO GU in January, and this is the data here that I'm going to go over with you has been recently published a few weeks ago in the Annals of Oncology. And here are the 3 data points that I would like to show you. And basically, to your left here is the OS, the Kaplan-Meier curve for OS, for, again, the primary patient population, intermediate and poor risk. And you can see here, the nivo-ipi patients are represented in the blue curve here. And there is an 11% improvement in OS for patients treated with nivo-ipi versus sunitinib. And at 8 years median follow-up, and here you can see the 90 months, that milestone, 11% improvement with OS. The median OS was close to 4 years for those patients treated with nivo-ipi, 46.7 months versus 26 months with sunitinib. Now moving here to this Kaplan-Meier curve plot with PFS, you could see here that, again, with 8 years median, you could see that a quarter of those patients treated with nivo-ipi are alive and progression-free. And you can see here there is a tail or a shoulder, plateau for that. So I think this is really important when we look at, durability of responses. And I think I'd like to draw your attention here to the hazard ratio, which over those 8 years from the primary analysis back in 2017, when this data was initially presented at ESMO, you can see the hazard ratio has remained stable here for OS, for intermediate poor risk, and it was 0.63 back in the primary analysis, and now is 0.69. And for PFS, it has improved from 0.82 to 0.73. Now, looking to this Kaplan-Meier curves here for duration of response, you can see that patients treated with nivo-ipi had a significant 4-fold quadruple improvement in median duration of response versus sunitinib, with 82.8 months versus 19.8 months with sunitinib. And it has a ratio here, you can see that it's 0.48. Now, moving to the ITT, or intent to treat population, this is, all the patients treated on this trial. Again, remind you that's 1,096, 1-to-1 randomization between nivo-ipi versus sunitinib. And you see here, those patients, ITT, are patients with all risks by IMDC. So you have the intermediate poor risk that I just showed you before, and the favorable risk all included here. And you can still see here at 90 months, the milestone here for OS for that nivo-ipi cohort was about, you can see here, it's about 10% improvement versus sunitinib. And the median for the nivo-ipi, median OS was 52.7 months versus 37.8 months. Come here to PFS. That has improved over time again, and you can see the hazard ratio here is 0.88. It was 0.98 before. And you can see here the median PFS, 12.4 months versus 12.3 months. But again, here you can see that the data is not as sharp as with the intermediate risk poor risk because of the inclusion of patients here with favorable risk. But again, when you look at duration of response for the ITT, again, it's more than double, 76 months median duration of response versus 25 months with sunitinib. And again, here you can look at these hazard ratios, 0.72, 0.88, and 0.52. It's important to note that 20% of patients receiving nivo-ipi who discontinued therapy remained in remission without subsequent systemic therapy. And this is something we'll come to when we talk about the concept of treatment-free survival. Now, what about the favorable risk? Favorable risk, we know that these patients do well and they live a long life. But initially, and you'll see here data from the IO-TKI regimens, that those patients, there has not been a compelling evidence to show improvement of survival for any IO-based regimen versus sunitinib. But over time, patients with favorable risk had an improvement in OS with nivo-ipi. And you can see here the median OS is 78 months versus 67 months. And the hazard ratio has improved over time from 1.45 down to 0.82. And this is compared to the primary analysis. But the PFS, of course, is still in favor of sunitinib. And here are your median PFS for nivo-ipi. So sunitinib obviously will produce a higher PFS, and you'll see it will be produce a higher ORR versus nivo-ipi for that favorable risk group. The duration of response, however, is still about double with nivo-ipi versus sunitinib. So even though the PFS is longer with sunitinib, when it comes to duration of response, it's in favor of nivo-ipi. Now, what about these responses? And here in red, in this red box, I show you the CR rate with nivo-ipi in the ITT and intermediate risk and in favor risk. And across the board, you'll see 12% of patients treated with nivo-ipi achieving CR versus 3% with sunitinib. And then even in that favorable risk category, as I mentioned, the CR rate is double with nivo-ipi compared to sunitinib. And you can see it at the bottom of the slides, the ongoing responses, of course, numerically, more patients achieve the responses, overall responses, as well as CR compared to sunitinib. And you can see here that over time, these responses, continue, they're ongoing. Now, what about this category of sarcomatoid? Those patients traditionally have had a poor prognosis when we treated those patients with the TKIs, like sunitinib, for example. And so we wanted to look at that subgroup of patients on the CheckMate 214 who had sarcomatoid dedifferentiation, whether it was focal or 10% or 90%, didn't matter, any pathology that had some sarcomatoid features in that tumor. We looked at those patients, and here are the numbers. And if, again, we presented this before, and this was published in two journals here. The update is the 60 months or 5 years. And this is the original publication in CCR, where the overall response rate with nivo-ipi in that group of patients who had intermediate risk, poor risk, and sarcomatoid dedifferentiation in their primary tumors or in a metastatic site, 61% versus 23% ORR. But this is the impressive thing, the CR rate of 19% with nivo-ipi. Now, after a longer follow-up here, the data has even improved a bit, where you had more patients who had favorable risk achieve CR, with the rest of the categories being stable disease, progressive disease, at 20% staying the same. But here you had 23% of the patients achieving CR with nivo-ipi versus 6% with sunitinib. Now, and here is on this slide, you see the Kaplan-Meier curves. Here to your left are the Kaplan-Meier curves for OS, and to your right, the Kaplan-Meier curves for PFS for the two treatment arms. And you can see here, there is a plateau. There is a plateau of about 50% of the patients alive past 5 years with nivo-ipi. And these patients traditionally had a median OS with sunitinib or similar TKIs of 14 months only. 14 months traditionally with TKIs, and now you see half the patients are alive, past 5 years. And you can see here the median OS, 48.6 months with nivo-ipi versus 14.2 months with sunitinib, and that has a hazard ratio of 0.46. And then when you look at the PFS, again, you can see here the median PFS is impressive with 26.5 months with nivo-ipi versus 5.5 months with sunitinib. And you can see here the plateau. You can see here about half the patients really alive and progression-free with nivo-ipi who had sarcomatoid dedifferentiation. So in my opinion, this is data that is compelling and that puts nivo-ipi as the preferred treatment in first line for patients with intermediate risk who had sarcomatoid dedifferentiation in the primary tumors. And here you see that the hazard ratios have really stayed stable from 42 months follow-up to 60 months follow-up. Now, what about safety and adverse events? And it's clear here on this bar graph that nivo-ipi, as well as sunitinib-treated patients, the toxicity was mostly the first 6 months, and over time, these AEs, whether they're immune-mediated of special interest or any AEs, they are lower as time goes by. Now, what are, I introduced the concept of treatment-free survival. What's the idea here? The idea is using immunotherapy can be associated with prolonged disease control after discontinuation of treatment, even if the patient had no toxicity or if they had toxicity. And so basically, there are some patients who you have to stop therapy because of toxicity, and that's what we did. But then the promising, about immune checkpoint inhibitor therapy is that those patients can really be followed without therapy if they had achieved a remission, a response, and if they had toxicity and you have to stop therapy. And so I can tell you anecdotally, I had several patients treated on this trial who had to stop therapy after 1 cycle or 2 or 3 or 4 cycles, and they remained in response, in remission, and 9 years later, they're still in CR, cured, hopefully, without any further therapy. So I think this is important to really underscore that the goal is to achieve a durable response and hopefully to stop therapy and see that response durable. So what's next now? The idea is, can we make this therapy more patient-friendly, more convenient for patients as they continue their maintenance therapy after the induction with nivo-ipi, with about 2 years of maintenance therapy with nivolumab. And I think the idea here has merit, because sub-Q administration provides an alternative with potential benefits for both patients and providers. Sub-Q dosing may alleviate the need for IV vein ports, allow more patient flexibility, reduce dose preparation and administration times, and optimize occupancy in infusion centers. And, atezolizumab has been FDA approved as a sub-Q formulation for patients with lung cancer and other tumors. And then we hope that I will show you some data to, show you how nivolumab also could be also the next immune checkpoint that has a sub-Q formulation that can be also approved here for our patients. Now, this is the trial that's called Checkmate 67T. It compared nivolumab sub-Q versus IV in patients with advanced metastatic RCC. These are patients who had clear cell RCC who received up to 2 prior lines of therapy with VEGF-RTKI. So they are treatment that are IO naive, so they did not receive any prior immune checkpoint. And they were stratified by weight and IMDC risk. And they were randomized to receive one of these 2 treatments, either nivo sub-Q or nivo IV. As you can see here, dose and schedule. And the 2 co-primary endpoints were time average serum concentration over 28 days. And here it is C average day 28. And trough serum concentration at steady state. And the key secondary endpoint was objective response rate by blinded independent central review. And I can tell you that the 2 co-primary endpoints were met. This was, again, a phase 3 trial with non-inferiority as a design. Now, what are the results? Here are the results. You could see that, obviously, there are more doses given with nivo IV because it's given every 2 weeks, and the sub-Q formulation is given every 4 weeks. But look at the time of administration. 4.7 minutes, obviously, it's no surprise here, versus half an hour to administer nivo IV. And then, importantly, the safety profile of both nivo sub-Q and IV were similar, and toxicity was manageable. And patients, importantly, reported being minimally bothered by treatment side effects on both treatment arms. So the quality of life was maintained for patients with advanced clear cell RCC while receiving treatment with nivo, regardless of the mode of administration. So the ORR was similar in both treatment arms, as you can see here in this box. And I turn it off to you now, Monty.
That's perfect. Thank you so much, Nizar. Terrific presentation. Thank you. And we do have a couple of questions for folks in the audience on your devices. So if you can potentially use your phone to scan this QR code, that would be terrific. And just a reminder, you can actually submit questions that way. So for those of you that have been to programs like this in the past with PeerView that I've hosted, I really like to throw some zingers to my panelists here. So we're going to do that once again tonight. And no easy questions here. We only have 5 minutes, so I'm going to get straight to the hard stuff. So we have a lot of stars from today's meeting. Dr. Moranchi led a session on non-clear cell kidney cancer today. Dr. Yingbei Chen gave a great talk on histologies, which I really appreciated. So Nizar, a patient comes to your practice, right, with this profile, 65 years old, intermediate and poor risk, and let's say this individual comes with a pathology report that says clear cell with rhabdoid features. Dr. Chen talked about that a little bit today. What does that mean to you in terms of treatment?
Well, that's a great question. I think we have to make a distinction between rhabdoid and sarcomatoid. They're not the same. Rhabdoid elevates the tumor to grade 4, so it's obviously an aggressive histology. But the data that I showed you with sarcomatoid is sarcomatoid. It doesn't extend to rhabdoid. We are looking at this actually. Hopefully, at our institution, we have a large number of patients, close to 500 patients treated with nivo-ipi, first line, who had clear cell and non-clear cell. So we're going to look at the question of rhabdoid versus sarcomatoid versus the combination or the mixture of rhabdoid and sarcomatoid. So for a patient who had sarcomatoid, whether it's focal or 99% sarcomatoid, the data, as I showed from the CheckMate 214, that's a subgroup analysis of the sarcomatoid, I think it's clear, and I think we all agree that nivo-ipi should be the treatment of preferred treatment of choice for that patient with sarcomatoid. For that patient with rhabdoid, I think other factors, I'm sure you're going to speak about that. We can discuss that. I think where the metastasis is it lung, lymph node, or is it bone, predominantly bone tropic? So that basically will factor in my decision of which treatment I would select. Just for disclosure, I presented the nivo-ipi data, but I have prescribed, and I do prescribe all 4 regimens. I have given nivo-ipi, and I have given the IO-TKIs. You're going to be going over that with pembrolizumab, nivo-cabo, and pembrolizumab. Sure. But I think for sarcomatoid, that's clear. I think there is consensus in the community of RCC experts to give nivo-ipi for the sarcomatoid.
Fair enough, fair enough. So Tien, let's say a patient comes to UT Southwestern to see you, 65 years old, intermediate and poor risk disease, and you have the pathology reviewed by your pathologist, and it's chromophobe with sarcomatoid features. Okay, chromophobe with sarcomatoid, not pure chromophobe. What's your go-to in that frontline setting there?
Well, we had some data from Sunny Forecast with ipi/nivo for the chromophobe population, but I inherently still have some hesitation to give ipi/nivo for chromophobe populations. I'm more of a VEGF-IO combination person for chromophobes, or even leaning toward monotherapies for these folks, because in our hands and our experiences, the chromophobe population just really haven't been as immune responsive. So that's my own personal sort of hesitation there, but there is some new data out just from ESMO a couple months ago, so that's encouraging. We also had a couple of patients on Brad's CANI trial with cabo ipi/nivo. So I think as these data mature and we learn more about chromophobe biology, I was really intrigued with all the ferroptosis and BCL-XL as a target, right, from Dr. Henske's talk today. I'm hoping there will be more targets to think about to really drill down on chromophobe biology.
Yeah, I'm a little torn there because in my clinical experience, if I look back at some of the durable responses that I've had for chromophobe with sarcomatoid features, it's been those patients that I put on nivo-ipi up front. But I think Laurence's data, and we saw some of it today in Brad's talk, is really compelling for the combination of lenvatinib and pembrolizumab there. Nizar?
I'd like to add to that. I agree. I think chromophobe is a immunologically cold tumor and unlikely to respond to immune checkpoint inhibitors. Although the data from Keynote 427B that David McDermott presented before and published in JCO 3 years ago, there was 9% response rate with pembro single agent in the chromophobe. However, I think the lenvatinib pembrolizumab, that was presented by Laurence at ESMO and published recently in the Lancet Oncology, showed a response rate of 28%. So whether this is how much of that was contributed by pembro and how much was that contributed by len, it's 29% response with chromophore. However, we looked at our nivo-ipi treated patients. As I mentioned, we have a large group of patients treated with nivo-ipi first line, and the chromophobe that responded to nivo-ipi were the ones that had sarcomatoid. So to answer your question, for chromophobe with sarcomatoid, we had 3 responders out of 8. We had 12 patients with chromophobe, 8 had sarcomatoid, 3 of those 8 sarcomatoid chromophobe responded, the rest, no response to nivo-ipi. So, and if you look at the Checkmate 920 published by Scott Tykody in JITC, recently, they had 0 patients with sarcomatoid respond to nivo-ipi. Yeah. So chromophobe doesn't respond to nivo-ipi, doesn't respond to nivo-cabo through that paper by Lee and his colleagues at MSK 2 years ago in Lancet, where they had 7 chromophobe, 0 responded to nivo-cabo. So I think right now the NCCN guidelines have included len-pem as a preferred or appropriate treatment for patients with chromophobe based on the B61, Keynote B61 that Laurence Albi just published in Lancet Oncology.
Your memory is incredible, Nazar. Wow, I am just blown away with it. You can pull out those elements from the MD Anderson data set at the tip of your tongue. That's mind-boggling. So last question in this section is going to go to you, Tian. So there's a patient, 65 years old, but not intermediate and poor risk, favorable risk disease. So they come out to California and see me at City of Hope, and I say, start on Cabo-Nivo. That tends to be my preferred regimen. Then they go to Nazar in Houston. Nazar says, oh, no, it's Nivo-Ipi. Look at the data. What do? They go to Dallas to see you. You're the tiebreaker. What are you going to choose?
Wow.
She's a Texan.
I say you've gotten amazing opinions from 2 very wonderful experts in the field. And, favorable risk disease, I do think there's time to see subsequent therapy. So it really depends on their goals. So I tend to have these conversations about what are their goals for treatment, and then look, is it complete responses? Is it, duration of therapy? Is it toxicity management? And, we navigate that conversation because I do think, all of these options are quite good for favorable risk disease. And if ipi/nivo has a good effect, that's great. If it doesn't, they have time to see other options later on.
That's totally fair. And it's a good way to respond since we're getting drinks after this, right? So very good. Perfect.
I need to keep my friends.
So we're going to shift gears a little bit. I'm going to be talking about IO plus TKI. And this is, again, data that I think is going to be well known to the crowd. So I'm going to go through it relatively quickly. And I want to leave lots of time for some more zingers at the end of this. So this is the most updated follow-up from Keynote 426 with about 67 months of follow-up here. As you look across this data set, there's in my mind sort of a modest difference in terms of progression-free survival, 11 months versus 15.5 months in terms of PFS. There's an OS advantage, but I'll never forget when Brian Reaney first presented this data. This was back at ASCO GU 2019. And it was almost a mic drop moment because you saw the OS at that time with a hazard ratio of 0.53, and it's really sort of crept up over the years. So as you can see here, the hazard ratio now is 0.84, and you can really sort of see these curves coalescing towards the end. I will say the difference in response rates that you see off to the right is appreciable, but this doesn't tend to be my go-to in the frontline setting. The trial looking at cabozantinib and nivolumab, Checkmate 9ER, it had a different patient population at baseline. This had a lesser proportion of individuals with favorable risk. It had a lesser proportion of patients that had their kidney removed. And so I would suggest that perhaps worse protoplasm from the get-go. Having said that, the data is really sort of held here with a hazard ratio of 0.58 for PFS. There's essentially a doubling in terms of PFS from 8 to 16 months. And you can see a persistent benefit in terms of overall survival with a hazard ratio that's holding at 0.77. And again, I think that there's an appreciable difference in response rates, as you can see off to the right. This is the data set that's maybe confused me the most for lenvatinib and pembrolizumab in combination. And that's because you see this really marked difference in PFS on the left there, 9 months versus 24 months. And certainly that constitutes the high watermark. You do need to really sort of dissect the patient population that was included here. This particular patient population had, in this case, a higher proportion of patients with favorable risk, fewer patients with kidney intact, some of these adverse prognostic factors that we look to. So maybe there was some expectation that they would do a little better from the get-go. I was really surprised to see the survival curves cross over the way that they have, at the tail end there. And the hazard ratio, again, here has crept up, approaching 0.8. Nonetheless, really impressive differences in terms of response, as you can see off to the right there. I wanted to spend a minute talking about management of TKI-IO toxicities, because this is different. When we talked about dual IO in the context of Nazar's excellent talk, if a patient experiences toxicity, it's the IO, right? But if you're using a TKI plus IO, it's really important that we figure out how to sort of suss out the nature of the toxicities here. And typically the way that we would do that in clinical practice is to hold the TKI and see if that toxicity resolves. So if it's a toxicity such as diarrhea, for instance, you'd expect that to abate after a period of time, perhaps more quickly with a drug with a short half-life like Axi. But at some point you can sort of tease out what the driver of that toxicity is and then manage accordingly. But I do think for the practicing oncologist, it's really important to know where these toxicities are derived and act accordingly. We're also very fortunate to have Dr. Chella in the room, who's really a founding figure in quality of life in kidney cancer. He's sitting there in the back. And he actually has done the foundational work for several of the scales for quality of life that you see here. So the FKSI-19, FKSI-DRS, these are really his invention. And we have separate scales here, the EORTC and EQ5D scales, that have been used fairly, inconsistently, I'll say, across these 4 pivotal studies. My general takeaway, though, is that there's indeed a benefit in quality of life with Nivo/Ipi long-term amongst patients receiving that regimen. And I think that resonates with my clinical practice. Those folks that are out several years tend to have a really good quality of life. For Cabo/Nivo, I also see that benefit. And I think this all is a figment of the dosing strategy with these agents. With cabozantinib, we're using a dose of 40 milligrams. That's lower than the 60 milligrams that we're using in the refractory setting. Whereas in contrast, in the CLEAR study, where you're seeing this impressive benefit in PFS, the quality of life by these current assessments seems to be a bit of a wash. And I think that's because we're using a higher dose of lenvatinib there at 20 milligrams, whereas what we're using in salvage is 18 milligrams, usually quickly followed by 14. So just a couple of quick words on what's next. I'm really excited about an agent called zanzalintinib. Zanzalintinib, when you look at it at first blush, seems to have a lot of resemblance to cabozantinib in terms of its mode of action. If you look in the bottom right there, you'll see familiar targets, VEGFR2, MET, and AXL. But it does have a shorter clinical half-life, 16 to 22 hours. The PK properties are a little bit different. There was an interesting poster that was presented at the Targets meeting just a month or two ago, really suggesting a distinct biodistribution of zanzalintinib. And then I think that really sort of lends itself to the tox profile that I've seen in using the drug in my hands in phase 1 studies. It does seem to be a bit better tolerated than other TKIs. I was particularly impressed when I saw sort of the cumulative data from some of these phase 1 studies that we participated in, and thanks to IKCS for allowing us to rush this in last year as a oral presentation. So this is data that we showed at this meeting back then, and we're working on publishing it now. The response rate in this cohort overall was 38%. And if you look off to the right, I think this is a really important sub-analysis because you really get a flavor for how zanzalintinib works in a population of patients that have received prior cabozantinib. So the expectation might be that this agent will work in those individuals who haven't received prior cabo, and certainly if you look at that subset of individuals, the response rate, and I'm pointing to the second bar here, is 57%. That's an impressive number indeed. But if you look at patients that have gotten prior cabo, despite the similarities across receptor tyrosine kinase profiles, you get a response rate of 24%. So I really think there's something to this. How is zanzalintinib moving forward? Well, there's the STELLAR-002 study that's evaluating cohorts of clear cell RCC in the frontline setting and the second-line setting as well. And you can see the combinations that are being explored with Zanza plus Nivo, Zanza plus Nivo/Ipi, and Zanza plus Nivo/Rela. And then there's a non-clear cell cohort too, which is very near and dear to many of our hearts in the room who focus on that on a day-to-day basis. I'm particularly looking for help from colleagues in the audience with this trial, which is called the Stellar 304 study. This study, it was highlighted today in Ben Maughan's talk, if you were, again, in Dr. Baranchi's session on non-clear cell disease. But the Stellar 304 study is looking at 3 distinct histologies: papillary, translocation, and unclassified renal cell carcinoma. And this is a 2-to-1 randomization to zanzalintinib plus nivolumab versus sunitinib as the control arm. And this is an international study that continues on. So I purposely wrapped up early so I had more time for zingers in this next section over here. And we do have a couple more questions for you, so if you don't mind scanning the QR code, we'll move on to some Q&A around this. So a couple of questions for the audience, for my panelists here, I should say. So we're going to take that same sort of patient that we described up front, 65 years old, intermediate and poor risk. And I'm going to jump to the second bulleted question over there because this is a really, really important topic in our clinic right now. So Tian, patient comes to you, right? They've gotten adjuvant pembrolizumab in a different practice. And they've started to progress about 6 months after initiating therapy with adjuvant pembrolizumab. What's going to be your mode of action in that case?
Yeah, so they're primary refractory during the year of treatment.
Exactly.
To pembro
and let's say this is overt progression. Let's say it's not just one solitary pulmonary nodule, but this is really progressive disease. 5, 6 pulmonary nodules emerging, a bone metastasis. What would you do?
Yeah, I think, we're thinking about PD-1 refractory disease as not really responsive either to adding CTLA-4 blockade. Personally, I would switch mechanisms, and so this would tend to be, a less immune responsive type of patient, and so I would change and do a monotherapy. Cabozantinib alone is very effective in that setting. We can also talk through the other VEGF TKIs, but I would be keen to switch gears.
To switch to cabozantinib. Nizar, what about you in that same scenario?
I think definitely I would not give anymore another PD-1 based on contact 3 and Tinivo 2. So I wouldn't go from pembro because the patient progressed on pembro to give them Nivo, say cabo. So I agree. The standard of care would be a TKI. Now, which TKI? I think you can choose now post anti-PD-1. But I would say there are several of us who are immunophiles who would say, unfortunately, the patient, after having progressive disease with pembro, or you're going to treat them with just a TKI, that you are basically, unfortunately, they may respond, they may live a few years, but we're not talking about cure here. And for that patient, if the patient is healthy and willing to try Nivo-Ipi, I would do Nivo-Ipi. And I think I speak on behalf of several of us who are in that camp of trying Nivo-Ipi after progression on pembro.
Really?
They may not have the results because we know there have been 4 trials showing that Ipi post anti-PD-1 is not going to produce the results. But I think there is still an option for Nivo-Ipi in this particular. And quickly we'll find out if the patient is not responding. Then you can go to a TKI.
And just to be clear, we're talking about primary refractory disease. So this patient's progressing quickly within a 6-month time frame on adjuvant pembro. You'd still try Nivo-Ipi there.
I would if the patient is healthy and has good organ function and willing to, with the understanding that the response rate and the benefit from it is going to be lower than if we had gotten a Nivo-Ipi up front. Obviously, Nivo-Ipi is not approved as adjuvant therapy, so we have to, but I have been offering Nivo-Ipi to some patients post-progression on adjuvant pembro, as I know some other colleagues who are, who they are. One of them is at your institution, and another one is Georgetown. Shall remain unnamed, but we know who they are. I think we are in that camp of Nivo-Ipi would be worth trying in patients with sarcomatoid, with progression on adjuvant pembro.
Very interesting.
Okay.
Okay.
I would be keen to see what the pooled, data are of those patients because I think the Hoosiers trial, the Omnivore trial, 920. I mean, there's a lot of data that suggests we shouldn't do it population-wide, but maybe for singular patients who have that goal of trying to achieve a cure.
Yeah, I definitely think there's no right answer in this setting, and I agree with you, Tian. I mean, it's going to be interesting to sort of pool these experiences and see how patients do in this context. But I'm going to sort of take us out of this setting for 1 second, and I'm going to ask you to pretend, Tian, for a second that I'm referring Dr. Montana. And I call you up, and I say, Tian, I'm seeing tons of these patients who have received adjuvant pembro and are progressing, and I can't send them all to you. So tell me, what is that time point when I should start re-challenging them with IO-based therapy? Is it 6 months following finishing therapy with adjuvant pembrolizumab? Is it 12 months? Is it 2 years? What's that line in the sand to restart therapy with IO?
Yeah, so for some of our frontline trials like Pedigree, we set that line as 1 year after finishing their adjuvant pembrolizumab monotherapy. So if they've had it a year prior and now they're progressing after the year, we would bring them onto Pedigree, and I think it's very reasonable to re-challenge then. I think from the nivolumab early, there was a study of nivolumab and T-cell activity where T-cells were active for about 6 to 9 months. So in my mind, that's sort of the cutoff of when I think patients might be resensitized to checkpoint inhibition. So if they've had, adjuvant pembro more than 6 to 9 months, we would have a conversation about dual immunotherapy checkpoint inhibitors.
That's good guidance. I've seen it all over the place, right, in protocols. I've seen 6 months in certain instances, 12 months in others, and I think that 6 to 9 month guidance is pretty consistent. Nizar, question for you. So a patient comes to your practice, and he actually has papillary renal cell carcinoma, widely metastatic disease. What's going to be your, let's say a clinical trial is not available, which is, by the way, never the case at MD Anderson, but let's say that you don't have a study in this setting. What are you going to offer
So
them
first line,
frontline?
this is first line, papillary. Okay, so we heard this morning that there is no papillary 1, type 2, there is papillary high grade or low grade. And I think we first want to make sure there is no molecularly defined. So if papillary features, so we will dig and do the NGS, next generation sequencing, trying to see. We'll have to rule out FH deficient. We have to rule out, ALK rearrangement, which we published on. We have to, but if it is, high-grade papillary, I think the data you published, you showed the first time that Cabo was better than sunitinib for the papillary. But we live in a world now where we have combinations. So I would not treat the patient with a single agent, except if it's a trial, like the PAPMAT2. I encourage to enroll on that, but off protocol, I would offer the patient a combination. So you have the choice of Cabo-Nivo, you have the choice of Len-Pem, and I think both will give an ORR in the range of about 50%. And it's in the publication from the MSK, again, Lee et al., the papillary patients had 47% ORR. The B61, Keynote B61 had a response rate of 54%. In those papillary patients. So at MD Anderson Nivo-Ipi, we have produced a 48% ORR. So I think you have any of those 3 regimens would be appropriate for papillary first line. Nivo-Ipi, 48% ORR. Nivo-Cabo, 47% ORR. Len-Pem, 54% ORR. So any of those 3 regimens would be fine. We have to see if the patient has hypertension. If you mentioned that in the history, and they're already on 3-4 blood pressure medications, then I would go with Nivo-Ipi. If they don't have hypertension, I may go with one of those 2 IO TKIs. Either one is fine.
Who needs slides when you have Nizar Tannir? That was very impressive, very good. I like them, very awesome. We're going to shift gears now, and we're going to wrap up with a talk from Tian on optimizing therapy selection and sequencing.
Great. Thank you. All right, we'll get this through. So many of us are used to thinking about refractory kidney cancer at this point. We often will think about what patients have received in their front line to think about what they'll receive in the second line and beyond. This type of pathway was really put together with the ASCO guidelines for kidney cancer. It's now published a couple years ago now, but I think they're still useful to kind of help us frame that. For some of the trials to highlight, Cabo Point is a trial that was run in France by our friend Dr. Albigez. This is a trial of pure second-line cabozantinib of all patients who had received immunotherapy, dual immunotherapy, or an immunotherapy checkpoint inhibitor with a VEGF-targeted therapy. Cohort A had patients with disease progression after dual IO. Cohort B had those with after disease progression with IO-TKI. And everybody was treated with cabozantinib 60 milligrams daily with a primary endpoint of objective responses. And you see sort of laid out the objective responses for the overall population as well as for cohort A and B. And I would just say, for cohort A, saw a good amount of partial responses, but no complete responders. Cohort B actually had a couple of, just one patient who had a complete response, but certainly cabozantinib in the second-line setting, I think, is quite active and a good agent for our patient populations. This is TiVo-3. This is a trial of tivozanib and versus sorafenib, and it was the registrational trial for tivozanib where 350 patients were randomized, and the progression-free survival was primary endpoint, and it favored tivozanib over sorafenib. So it did give an indication, FDA approved in the US as of March of 2021, and we are using tivozanib in our clinics now. I really love to talk about HIF-2 alpha inhibition. Usually I give about an hour-long talk, so for this one slide, we'll compress it all. But this is beautiful work that was translated from our labs at UT Southwestern, and it's really been amazing to think about a target that wasn't thought to be targetable, HIF-2, and the dimer of the HIF pathway is a transcription factor, and so was thought not to be targetable, but it is really smart chemists on campus found that the PAS-B domain, where the intersection of HIF-2 alpha and HIF-1 come together, is targetable with a small molecule. And so there was a molecule discovered on campus, PT2385 that you see there, that subsequently got altered a bit with structure-based drug design to have more bioavailability to be PT2977, and subsequently this became belzutifan that you know today, and it is a very potent HIF-2 alpha inhibitor. The HIF-2 alpha inhibition with belzutifan was then taken to a registrational trial, which you may be aware of, LIGHTSPARK-005. These were patients with unresectable, locally advanced or metastatic clear cell kidney cancer, randomized to either belzutifan or everolimus. And patients had a progression-free survival as their primary endpoint, and you do see, even though crossing of the curves in the first 6 months, as we got out to 2-year follow-up, the hazard ratio was 0.75, favoring patients treated with belzutifan. And the objective responses were about 22.7%, much higher than those treated with everolimus. The overall survival was updated, and we did not see any improvements in overall survival, but this is a very mixed population. It was not the primary endpoint for this registrational trial. So belzutifan is now approved in the refractory setting. There's now some really nice therapeutic selections in refractory disease. We have to think about how does immunotherapy re-challenge affect our clinical outcomes? Can those outcomes be affected if non-immune checkpoint inhibitors were used before the re-challenge? And are there any differences between PD-1 or PD-L1 effects? And so lots of different combination approaches have been tested for refractory disease. So you heard Dr. Tannir talk a little bit about CONTACT-03, TiNivo-2, and these randomized approaches not showing much benefit of using dual immunotherapy after prior IO failures. So what about these combination approaches? This is the phase 3 CONTACT-03 trial where we randomized patients to either cabozantinib monotherapy or atezolizumab with cabozantinib. We did not see a benefit of either progression-free survival or overall survival. And so this is not one of our preferred combinations, particularly in the refractory setting. T-Nivo2 was presented just this year, and for the intention to treat population, we also did not see an improvement in progression-free survival. This was tivozanib versus tivozanib with nivolumab. I think for a variety of reasons, I think, could it be the dose, could it be the population, but these trial really helps us sort of frame, cement that concept that dual immune therapy ICI with a VEGF in that refractory setting is not preferred for our refractory patient populations. How about tivozanib monotherapy as the control cohort from T-Nivo2? This was tivozanib after prior immunotherapies. And if you looked at those who had immunotherapies as their most recent therapy, this favored tivozanib alone, 9.2 months for median progression-free survival. So the monotherapy of tivozanib is actually quite effective in that setting. So it is an option in refractory kidney cancers. We often will think about monitoring and managing side effects. Tivozanib side effects are not much different than most of our VEGF TKIs, but hypertension, fatigue, diarrhea, hand-foot syndrome are things that we would discuss with our patients ahead of time and have them look out for so we can jump on early management as they get started. How about belzutifan? We have some effective therapies, and so how about combining belzutifan with our TKIs? LIGHTSPARK-003, as you see on the left, was belzutifan with cabozantinib. This was a single cohort phase 2 study with an objective response rate of 31%. So a nice effect of the combination. There is a phase 3 trial ongoing. This is fully enrolled, LIGHTSPARK-011, with the combination of belzutifan with lenvatinib versus cabozantinib alone. So we'll be looking out for those data, hopefully in the months to year ahead. All right, before we move on, if you could take a moment to answer some questions on your device, please, through that QR code. And then we will move on. So what's next? What are we excited about in terms of sequencing? Well, I personally am excited about a phase 3 pedigree trial that I run through the Alliance Cooperative Group here in the US. This trial we've been working on since 2014, believe it or not, for the past decade, and it's enrolled over the last 5 years, but now is fully enrolled at more than 1,100 patients. We've randomized almost 600 patients now, so everybody is treated with Dr. Tannir's favorite dual immunotherapy up front, Ipi/Nivo for intermediate and poor risk disease, and adapted for their responses at 3 months. If they have non-progressive disease and non-complete responses, these patients will receive nivolumab with cabozantinib versus nivolumab alone per Checkmate 214. And so the primary endpoint is 3-year overall survival. I always say the longer we wait, the better for our patients, and hopefully we will see some good data to follow in the coming years, so stay tuned for that. What else is exciting and new in refractory kidney cancer? I think we saw some really cool data for CAR T cells today. Those are not even on the slide, but there was a really interesting microbiome study that was highlighted at ESMO this year of fecal transplants. They took a really wonderful, exceptional responder to nivolumab and took his fecal matter and were able to develop it into frozen pills to transplant into their patients, getting immunotherapies, Axi/Pembro, and randomized 25 patients to either the fecal transplant or placebo, and amazingly saw some nice activity for the transplanted patient population. So more to come, I think, on microbiome. I know it's a topic close to your heart, Monty, with CBM-588, as well as there's a molecule called camu-camu that's a supplement in the South American fruit. So I think lots more to come from microbiome work. At ASCO this year, Dr. Vashampayan presented of a TGF-beta trap. This is a really interesting way to target immune escape and resistance to immunotherapy checkpoint inhibitors. And so the data from the DRAGON trial were presented showing some patients who had good objective responses even in heavily pretreated refractory kidney cancers. There are some antibody drug conjugates coming down the pipeline as well, ENPP3 as well as CD70. We've been talking about CD70 quite a bit this conference, but I think these are some great targets. And then bispecifics, also ENPP3 there is a good target in kidney cancer for bispecific agents, as well as EGFR. We have an agent in our phase ones that is looking quite promising. And then finally, speaking of trials available at MD Anderson of CA9, there's also radioimmunotherapies with lutetium, girentuximab targeting CA9. So that is ongoing and in trials now. So very exciting, I think, landscape for what's coming down the clinical pipeline and trials to look out for in the years ahead. I do think it's still a challenge to tackle refractory kidney cancer. These are many mechanisms of thinking about immune checkpoint inhibitor resistance, and we haven't been as careful as our lung cancer or breast cancer colleagues, for example, in insisting on serial biopsies to really drill down on the mechanisms for when patients are progressing on checkpoint inhibition. And so as we understand these pathways for resistance more, hopefully we will get to more rational targets for our patient populations and better outcomes in clinical development. And so I'll hand it back to you, Monty.
That was terrific, Tian. Thank you. That was terrific. And I love that you left me plenty of time for more zingers. Thank you for that. Perfect. Perfect. So, I'm actually going to try to reflect a lot of the audience questions that we're getting here. And I would say at least half of them reflect therapeutic sequencing. So, Nizar, a patient comes into your clinic progressing on Nivo/Ipi. What is going to be your de facto sort of second-line standard, again, outside of a clinical trial?
Sure. This is the most important, the most common scenario, oncologists are facing, because unfortunately our patients are not all of them cured with first-line therapy. So if they are TKI naive, I think traditionally I have used axitinib post-Nivo/Ipi, unless the patient has poor risk, multiple bone mets, then I would use Cabo. That's been so it was, and the reason is, I know I can give Cabo after Axi and salvage them. I know I can give lenvatinib, everolimus, after Axi and Cabo and still help them. And we published on that in The Oncologist a couple of years ago, or 3 years ago now, where we showed activity of lenvatinib, everolimus after Cabo. The other way around has not been, we had a poster at ASCO GU where, post, let's say, len-pem, Cabo is not as effective. So, we have the data from Meteor that shows that Cabo is a good agent after TKIs, but you can't. Now, with TiNivo-2 data, I think it is important. If you're going to give tivozanib, the sooner you give it, the better. And we published recently, again, in The Oncologist, earlier this year, where we gave Tivo after, Nivo/Ipi and Cabo and lenvatinib, and the response rate was low, and the PFS was short, 7.7 months ORR, and median PFS 3.8 months with Tivo, if you're going to give it after 4 prior lines. So now I would give, Tivo in the second line. We have the TiNivo-02 data that showed, you showed it, Tian, that patients who had second-line therapy had a median PFS of 9.2 months if they had just Nivo/Ipi, and then they went on to Tivo from the TiNivo-2. So it makes sense to give Tivo, and then Cabo, and then Lenev, and then belzutifan. And why belzutifan later? Because we recently published in the European Urology Focus, after 5 prior lines of therapy, belzutifan produced good results, 36% ORR and a median PFS 8.6 months after 5 prior lines of therapy. So belzutifan, you can salvage patients post multiple lines of TKI. You can't salvage patients with a TKI like tivozanib after many prior lines. So you have to give tivozanib in the second line if you have hope to produce any benefit with tivozanib.
That's an interesting philosophy. Mine's quite different. I mean, I tend to sort of see this rule of diminishing returns across lines of therapy and, a lot of attrition, frankly, from first to second to third line. So if I see a patient progressing on nivo/ipi, I tend to use cabo second, then I tend to, sequence tivozanib for the most part after that, occasionally Lenev for a very robust patient. So, let's say a patient comes and sees me at City of Hope in the frontline setting and gets nivo/ipi, is progressing on that, and I say to them, I think cabozantinib is your best bet, followed by tivozanib. But then he flies to Houston, Tian, and sees Nazar, and Nazar says, no. Nivo/ipi, then axitinib, then maybe cabozantinib afterwards. Flies to Dallas for the tiebreaker. What are you going to tell him?
I
No
have
pressure.
to be the tiebreaker every time.
No pressure.
I think cabo is a great drug, and so it depends a bit on how symptomatic they are. I agree with Nazar that if they are very symptomatic, we don't think they're going to see another line. I would be reaching for cabo. If they are able to see multiple lines in sequence, and we have patients now in our clinics that have received 5, 6, 9 lines of treatment, and so we need to use all the life-extending therapies in our armamentarium, right? And so we can sequence many of these agents, and I think when we think about these agents is really dependent on how symptomatic they are and how they're progressing. And so I think both have very good merit, and we just discuss, how they want to tackle the disease.
Okay, got it. So, I'm going to quickly, and we'll have to give short answers. We're quite short on time here. Patient starts on cabo-nivo in the frontline setting. They come to see me at City of Hope. Right? And I'm going to suggest to them TiVo after that. That tends to be this algorithm that I've adopted for quite some time now. It's a very sort of common sequencing strategy in my practice. Then they go to see Nazar, and Nazar says, well, you've been on cabo-nivo, your next step should be, what would you typically use there, Nazar?
I think TiVo is reasonable here because, again, the TiNivo 2 trial showed that if they received only one line prior to TiVo does produce results. So I think it's reasonable to try TiVo. And, again, SEER data said that, only 50% of patients go from first line to second line, and only a third or 30% go to third line. At MD Anderson, median number of lines patients receive is 6. So we have patients who go through first, second, third, fourth, fifth, and more. So I think TiVo is reasonable, but I think, Lenev would be reasonable, belzutifan will be reasonable. You have to really look at, again, as we discussed, did the patient have proteinuria? Do they have nephrotic range syndrome? Do they have hypertension? Are they on 3-4 blood pressure medication? If that's the case, belzutifan, different MOA, they go to belzutifan to avoid the hypertension and proteinuria. No hypertension, no proteinuria, tivozanib is reasonable.
Okay. Well, we were supposed to say something different so we could throw it to TN for a tiebreaker, but let's say they fly to see both of us, and we're both saying cabo-nivo followed by TiVo. What's your thoughts there for a patient that starts on cabo-nivo up front? What's next?
Yeah, I think it's quite reasonable. Cabo-nivo followed by tivozanib. I think that Lenev, if they're very fit and functional, they can tolerate side effects, and then belzutifan is a good option. I probably save it for after tivozanib, but to really try to figure out, we still need a biomarker, right, for belzutifan, the patients who will have good responses on belzutifan. And to me, the crossing of the PFS curves in the beginning 6 months says that some patients will not respond as well as I would like them to. So I'm still in a bit of a quandary about who's that HIF-driven patient where we want to give belzutifan after cabo-nivo.
Perfect. Well, I think that takes us to the hour, and I just want to thank both of you for being amazing colleagues and panelists, and
Thank you.
I really had a lot of fun in the discussion.
Thank you for moderating a great program and for all these questions. But we do agree on some things.
I guess so, yeah. It's not so different.
Round of applause for Monty.
Well, if you don't mind, don't forget to